I'd like to thank Drs. Norsey and Timken and the organizing committee for the opportunity to speak on cervical cancer and offer some brief observations on clinical trials. These are my disclosures. As we all know, cervical cancer is a global problem, representing 3% of cancer cases and deaths in women. As depicted, cervical cancer is the leading cause of leading cancer in women in sub-Saharan Africa, as well as other underserved portions of the globe. While data from the SEER Cancer Registry clearly demonstrates a decrease in the incidence of cervical cancer, it is very important to note that in spite of this improvement over nearly 40 years, African American women have a higher baseline risk of cervical cancer, and that in spite of refinements in screening technology and pending the future hopeful positive impact of the introduction of HPV vaccination, we have seemingly made little ground in the last decade of the management of this disease. Both internationally, as depicted earlier, as well as nationally, cervical cancer is more common among underrepresented minorities, and by and large, greater numbers of cases are clustered in different parts of the United States, including the Southeast, Northeast, Mid-Atlantic, and Midwest. And certainly we've heard this many ways during this morning. Importantly, both NCI designated comprehensive cancer centers, as well as members of the National Comprehensive Cancer Network, are in most, but not all of the states with higher than average rates of cervical cancer. These sites have traditionally been active participants in cervical cancer clinical research. Considering the management of locally advanced cervical cancer or cancers too large to perform a surgical resection, such as a radical hysterectomy, sentinel and paradigm-changing work funded by the NCI and different clinical scenarios where platinum was added to radiation therapy led to an NCI clinical alert regarding the need to incorporate this potential life-saving therapeutic approach for women with cervical cancer. This is a rare feat. It does not happen every day. It does not happen every decade. Nearly 1,900 women were treated in these 5 sentinel trials, and although race and ethnicity were not fully reported, in aggregate, approximately 43% of patients were classified as racial or ethnic minorities. Again, how often does this happen? Although not depicted, data from these randomized controlled trials, the gold standard in clinical research, was associated with both improved progression-free as well as overall survival. And more importantly, most of these studies have had long-term or secondary publications that have confirmed the initial trial observations. As many know, the previously mentioned National Comprehensive Cancer Network sites evaluate clinical trial information in order to formulate recommendations for the ideal management of patients with different types of cancer, including cervical cancer. Although not all of the scenarios listed can be evaluated in clinical trials, the NCI has been integral in supporting research which informs and guides modern treatment of women with cervical cancer. Representative NCI trials, and to Dr. Mannel's point, many of which were in the heyday of the GOG, from the Gynecologic Oncology Group and NRG Oncology are depicted in red. Although guidelines are important, more important perhaps is that those treatment guidelines are in fact followed. This sobering SEER data from over 7,000 women treated with external beam radiotherapy demonstrates that just over 1/2 of women received guideline adherent care for locally advanced cervical cancer, which includes brachytherapy. Let me repeat that. Just over 1/2 of all patients receive standard of care treatment for locally advanced cervical cancer. Moreover, outcomes still vary by race, with inferior survival seen among those that were older, had public insurance, and were Black. However, and again, perhaps most importantly, is that for women that received brachytherapy, again, part of the known standard of care, as per national guidelines, survival was similar thus seemingly overcoming these baseline disparities. I would now like to offer a few brief observations on cervical cancer from Alabama. Unfortunately, Alabama has a higher incidence of cervical cancer than many states in the Union. 5 counties depicted in red stand out for a much higher rate than the remainder of the state, including Dallas, which is depicted by a star county, which includes Selma, Alabama. The 5 counties and their incidence is listed at the right. Like other investigators, we evaluated the potential impact of the distance from our comprehensive cancer center, the only one in Alabama, and for a period of time, the only one providing comprehensive gynecologic care, on the outcomes in women treated over an 11-year period, the majority of which, or about 59%, that underwent a primary surgical resection. We noted that while not statistically significant, absolute differences in progression-free survival were present. In spite of similar demographic and tumor characteristics, to include, among others, treatment, age, race, and tobacco use, among others, more worrisome was the observation that overall survival did appear to be inferior for those women living greater than 100 miles and having to travel to our comprehensive cancer center. A heat map of patients seen is depicted on the left. Using this informational distance, we attempted to look at other potential predictive factors for the development of advanced stage cervical cancer in Alabamians, as this therapy is more challenging and requires daily radiation treatment. Patients with stage 2 through 4 cervical cancer were compared to a control group of women with stage 1 cancers. Utilizing zip codes, we evaluated the distance for individuals' patients from ACOG providers as a surrogate for access to Pap testing and screening. While distance to provider, as well as geographic portions of the state, did not appear to predict a higher stage, age, race, and public insurance were again associated with a higher likelihood of developing advanced stage cervical cancer in this observational study of nearly 1,000 women. Shifting gears, while the NCI has historically been instrumental in supporting cervical cancer research, the 2 most recent FDA therapeutic approvals, both within the last few months, came from outside of the NCI-funded research. Both the antibody-drug conjugate, tisotumab vedotin, which can be combined with other active agents to treat cervical cancer, as well as the addition of the checkpoint inhibitor pembrolizumab to the triplet chemotherapy regimen of paclitaxel, platinum, and bevacizumab, were evaluated, again, outside of NCI mechanisms. In conclusion, while the NCI has offered tremendous support, which has resulted in meaningful clinical trials that guide everyday treatment decisions for women with cervical cancer, pharmaceutical-sponsored trials have resulted in the last 2 approved agents in managing this cancer. And again, Dr. Mantle referenced this earlier. Importantly, different approaches, as most of us have noted, will likely be necessary in different parts of the country, where access to care and distance from care is highly variable. Lest we forget, screening and vaccination. Screening and vaccination as primary prevention need continued support to help further decrease the development of this terrible yet highly preventable malignancy. It is clear that we cannot rest on our laurels of positive clinical trials and a prior NCI clinical alert, and must ensure that all parts of the population have access to life-preserving clinical trials. Although it shouldn't be needed, can we further incentivize sites to ensure equitable representation, equitable representative enrollment on clinical trials? Recently, NRG GY022, which is evaluating the pharmacokinetics of carboplatin chemotherapy administration in both clinical trials and as part of standard of care chemotherapy administration, was closed to female accrual in order to obtain information for male patients, as women were grossly overrepresented in the study. While obviously this approach will not work in and of itself for cervical cancer trials, Novel approaches are desperately needed to guarantee that clinical trials can in fact be all that we want them to be. Thank you again for this opportunity to speak this afternoon.